Our first speaker this afternoon is Dr. Michael Yeh. Dr. Yeh is an associate professor of surgery and medicine at UCLA, and he is chief of our section on endocrine surgery. Dr. Yeh is going to be discussing some common sort of endocrine surgical problems. Dr. Yeh.
Hi, good afternoon, everyone. I hope you enjoyed your lunches, and thanks so much for coming back for the afternoon. I'm learning a lot from this session. As a surgeon, I probably didn't need to know quite so much about STDs and vaginitis and, the whiff tests, but I feel like I'm now armed and dangerous as regards counseling my pre-adolescent children. I just this one disclosure. And I just wanted to start out by saying the Mayo brothers once said that given one well-trained physician of the highest type, he will do better work for 1,000 people than 10 specialists. So you're going to hear some subspecialists talk this afternoon, but as a subspecialist, I know that I am completely dependent on good primary care physicians to establish the right diagnosis. Otherwise, I would be nowhere. And I just want to tell you I have the utmost respect for what you do. So a few learning objectives. So what is endocrine surgery? I've met a few of the other attendees at lunch. I mainly deal with thyroid, parathyroid, and adrenal diseases. I have one foot in the medical world and one foot in the surgical world. So we'll talk about some of these common things: solitary thyroid nodule, hypercalcemia, and adrenal incidentalomas. All of you will see these things many times in the upcoming year. And I've changed the content quite a bit from what you have in the syllabus. It's because there are things in each section that I'm going to present to you that are updated within the past 4 weeks. Okay, so I want to bring you the very freshest content. I'm going to split this up into what's review and what's new. All right, so here's your first case, a 36-year-old woman, 2-centimeter lower central neck mass. And what are the important points on H&P? You guys just call a few things out. Well, radiation exposure. Looking for a parotid lesion from that side of the room. What are you going to ask her? Is it tender? Timing? Is it growing? Somebody from here? Here's a family history. Thank you. Those are all the relevant points, right? So history of growth, signs and symptoms of hyperfunction. You want to know is the patient hyperthyroid. Change in voice. That's important because if it's a malignancy and if it's invasive, it can take out the recurrent laryngeal nerve. That's rare, but if you do see that, we have a patient coming in this week with this problem, then it's usually invasive cancer. Radiation exposure, and at what age? The younger you are exposed, the more likely that it is to give rise to a thyroid cancer over the long term. Any compressive symptoms, trouble swallowing, trouble breathing, etc. Family history, Family history is very important, and of course these usual things on physical examination. All right, so I'm just going to give you the most common scenario. She's euthyroid, she's asymptomatic, she has a negative history, and she has a solitary nodule. Very common problem. So my next questions for you are what labs, from that side of the room, what labs do you want to get? TSH. Anything else? Pre-T4, maybe, yeah, okay. How about imaging? Ultrasound, good, a lot of consensus about ultrasound. And then, of course, we move to invasive testing. I'll spend most of this section, the first 10 minutes on thyroid, about invasive. It was non-tender. Most of them are indeed non-tender. Once in a while, if it is tender, often that reflects underlying autoimmune disease, such as Hashimoto's thyroiditis would be a common in the differential. Okay, so TSH is, if you look in terms of cost effectiveness, that's probably all you need. At UCLA now, if you order TSH, you can order it as TSH with reflex. So if the TSH is abnormal, then the test has a built-in logic to it that allows you to get a T4 and T3 reflexively. Ultrasound, cost-effective. The neck is very superficial, so you can get a good view in most people. And then, of course, FNA. FNA is kind of the workhorse of a thyroid nodule evaluation, as you know. So we'll talk a little bit about that. Okay, so thyroid nodules are really common. There was a study of 45-year-old German factory workers. Everybody got an ultrasound, and some half of the adult population has thyroid nodules. Almost all of them are benign. So the issue with thyroid nodules, I think, is avoiding overtreatment. I think we have to really be diligent about that. Otherwise, we could be sending all kinds of people off for surgery that they don't need. Management is largely determined by the needle biopsy result. All right, so here we go, a little bit about FNA, and this is the review portion. Ever since, for several decades now, and this is a classic paper by Ernest Mazzaferi, New England Journal, fine needle aspiration has become the initial test in most patients with solitary thyroid nodules. We don't get too many thyroid uptake scans anymore. That was determined not to be cost effective. You might get one in somebody who's clearly hyperthyroid or a suppressed TSH if you're looking for a hot nodule. And the nice thing about a hot nodule is they're almost always benign. If you think about it, it makes sense. So well differentiated, making all that thyroid hormone, right? All right, so the nice thing about FNA, it's safe, it's simple, it's accurate, it's very cost effective. It's one of the best tests we have in all of medicine. Sensitivity, very high, about 95%. Specificity, extremely high, 99%. Hard to beat that in any sort of test. So a benign FNA is very reassuring. And a malignant FNA, I get this all the time, doctor, is there any chance that malignant FNA is wrong? No. Don't bet on it. It just hardly ever happens, okay? And it reduces the number of unnecessary operations and it increases the cancer yield of surgery. This has been true for 20-some years. Okay. Now, so you guys are experts in giving anticipatory guidance. So if you get an FNA, I tell the medical students, don't just send them off to get an FNA. Tell them what they could potentially expect as a result, right? And people always want to know, what is the worst case scenario, doc? What's the worst thing that could happen to me? So most of the biopsies are benign, very reassuring observation. There is about a 5% false negative rate. So that, again, that goes back, the onus goes back to you to examine that patient in a year, get an ultrasound in 6 months based on your clinical judgment. If the biopsy is malignant, well, they need a cancer operation. Now, I want to call your attention to this category in the middle, suspicious. And the terminology is widely variable. Cannot rule out neoplasm. You guys ever seen that one? Papillary cancer cannot be excluded. Atypia of undetermined significance. So whenever you hear this sort of hedging language, you're in that intermediate or suspicious category, which you may get in up to 25% of cases. I've just highlighted the middle section here, okay? Now, conventional management, those people go to, so the risk of malignancy in a suspicious nodule is about 25 to 30%. So I tell the patient, well, the odds are in your favor. Most likely it's still benign, but we don't know. And in a healthy 40-year-old woman, I'm not going to take the chance of leaving a cancer in, a 25% chance of this cancer to grow unchecked within your body is not acceptable, right? And so usually they go to diagnostic surgery, also known as diagnostic hemithyroidectomy. Now, after that operation, most of them turn out benign, some of them turn out malignant. If it's benign, they get a phone call from me 1 to 2 days after surgery. You don't need anything further, ma'am. And in the back of my head, I'm always thinking, ma'am, was that an unnecessary operation? Yes, right? That patient got too much surgery, right? So I tell all my patients, we don't want too much surgery, we don't want too little surgery, we just want just the right amount of surgery. That patient had too much surgery, and then the person who has a malignant biopsy has to come back for a completion thyroidectomy 10 days later. That patient had inadequate initial surgery, right? So neither one of these folks really got what they deserved, I think. And also, if you think about it, a biopsy should just tell you yes or no. The intermediate category is the least useful determination, okay? So let's focus more on this conundrum. Complicated tree. What can we do better? We can risk stratify people with suspicious nodules based on what you told me. Family history, radiation exposure, ultrasound features, okay? We can stratify them into high risk and low risk. Thankfully, most of them are low risk. And we can use a new test, and I know Dr. Sakiyama touched on this a little bit yesterday, right? The gene expression classifier, which is a commercially available test. I'm not going to talk too much about that test per se. I mainly want to focus on the logic that goes behind ordering these and the probability theory that goes into making the best choice for your patient. Now, the GEC, gene expression classifier, is effective in ruling out malignancy. We're going to talk about a little bit more about the probability theory behind that. But if that one is benign, which it comes out benign in about half of cases, that's highly reassuring. 95% of those are truly benign, and those can be safely observed. So let's think about that conceptually. You took a suspicious nodule with a risk of malignancy in 25 to 30%, and you reduced the risk of malignancy after the negative gene expression classifier to about 5%. Now, there's always going to be a small false negative rate, right? No matter what test you're getting. But if you think about it, the expression classifier allowed you to group this patient, lump them together with all those people with benign morphologic cytology. They're statistically no different, and those people we are safely observing. Now, it doesn't mean you're going to let that patient go into outer space. You still got it. You counsel them about the false negative rate. You bring them back for an ultrasound in 6 to 12 months, all right? So, GEC, helpful. In some cases, the GEC turns out suspicious, which is not that helpful because you're still going to diagnostic hemithyroidectomy. And the way to think about that is you just spent $3,000 on the test, and your management is not changed from if you had not gotten the test at all. Got it? So that's the non-value added arm of that test. All right. What if you have a patient with high-risk features? Let's say the pathology, you have good friends with your pathologist, and they say, I'm a little worried about this one. It has nuclear atypia, and oh, the patient has 2 first-degree relatives with thyroid cancer. That patient's having surgery, right? There's nothing that's going to talk you out of an operation for that patient. You only have the true answer when you have the histopathology, the paraffin and beta blocks in your hands. So in those high-risk cases, you can get something different called a gene mutation panel. How is that different? The gene mutation panel looks for specific mutations that we know cause cancer. So the gene mutation panel is good for ruling in malignancy. If any one of those is positive, you almost certainly have cancer, and that patient should have a cancer operation. In other words, we want to push as many people into this or this and have very little of this. Does that make sense to folks? We want very little of that sort of inadequate surgery, arm. We just want either to avoid surgery or to do one definitive good cancer operation for you. It turns out that, I'm sorry, these numbers I meant to change, but most of the GMP, gene mutation panel, 85% turn out negative, and only a small fraction, 15%, end up positive. I'm sorry for that small typo. All right. Now, you may be wondering, why do we have 2 different genetic tests for thyroid cancer? Why not just have one? It's because all this science is rapidly evolving, all right? So I'll talk a little bit about, I'm sorry, I know can see you guys going through some of your papers. I'm sorry I changed it quite a bit. Again, this is all very new data. It's within the past 6 weeks, and I'm sorry. So if you could just please follow along with the lecture part, and I can send you a revised syllabus later. I apologize. I know I'm going to get a few complaints about that, but I just felt, you deserve the very latest. I'm sorry. So the gene expression classifier is highly sensitive, okay? The specificity is only 50%. So the way to think about the gene expression classifier, which is commercially available, it's marketed as the Veracyte Afirma test, okay? It's like a trigger-happy fire alarm. Let's think about that for a second. So it's a fire alarm that's very, very sensitive. If you sneeze on it, it rings, right? So if it's ringing, there could be a fire, there might not be a fire. But if it's silent, there's no fire. You with me? Very, very sensitive test. So it behaves as a unidirectional test that is really value added when it is negative. Okay? Why are the numbers that they are? It's just because of the fundamental underlying science of the test. So it's useful in ruling out malignancy and adds value when it's negative, which is about half the time. And this is maybe the most important thing you can take away that's new about thyroid nodule diagnosis, is if you have a low suspicion thyroid nodule, and the cytology is in that middle category, you can save about half of people from getting unnecessary surgery if you use this test. I think that's pretty good. All right, what about the gene mutation panel? This is the one you've heard less about, okay? It's highly specific. These are the genes that are tested, these specific mutations. Meaning, if you've got one of these mutations, we know that these mutations cause cancer, and you probably have cancer. So this is the fire alarm that doesn't do anything until there's absolutely a fire. It's silent, it's silent, it's silent. So if it's silent, meaning the test is negative, could the patient still have cancer? Yes. However, if it's ringing, if that fire alarm's on, you better get up and book out of the house, because there's for sure a fire. Got it? So this is a highly specific test. Rules in malignancy and adds value when it's positive. So I'm just going to take you back to this, and I'm sorry for the complicated tree, but you're going to exercise your clinical judgment here in the suspicious thyroid nodule. And I point out that if the morphologic, if the standard cytology is malignant, that's all you need. If the standard cytology is benign, That's all you need. It's just for this intermediate category when your cytopathologist is saying to you, when I look at the shapes of the cells on this biopsy, I'm not quite sure, and your answer to your patient could very well be, let's look at the genetic material inside the nodule, okay? All right, to summarize, most thyroid nodules are benign. You want to avoid overtreatment. Sometimes this means if it's a very small nodule, below a centimeter, don't biopsy it, unless you have a really good reason to. Unless you're concerned about internal calcifications, invasive features, radiation exposed as a child, then maybe you might biopsy it. But the standard 45-year-old female patient with a non-specific looking thyroid nodule less than a centimeter, I mean, millions of people have those, and we should just let them be. What's new is molecular profiling. The value of molecular profiling is greatly enhanced by the rational use of technology. This is really the key sort of cognitive point I have for you, which is you can spend thousands of dollars if you just use these molecular tests in an indiscriminate fashion. Okay, because those companies that market them are happy to take your money, happy to. I mean, you could debate whose money that is. Is it taxpayer money? Is it the insurer's money? Is it the patient's money? But sometimes the cost of one of these tests is actually greater than the cost of the operation. All right, sometimes the $3,000 to $4,000 is a lot more than we'll make for the operation. So be careful. Exercise good judgment and utilize them with the logic I showed you so that you can apply them selectively and not just, if you just shower them all over your patients, then the only person who's going to be winning that is the test company, all right? So, and the field is rapidly evolving, and I'm sure you're thinking, well, it doesn't make sense to have one test rule in malignancy and one test rule out malignancy. It should just be one genetic test, right? And it's going there. And one reason I've updated these slides is because every 6 months there's another publication about this showing that they've, you know, the high specificity guys are working to increase their sensitivity, and the high sensitivity guys are working to increase their specificity, and it's all going to merge in the middle sometime in the next 5 years. All right, so your second case is a 44-year-old man with renal stones. I was talking with one of the course attendees about this very patient and difficulty concentrating. He has high calcium, and maybe I'll ask you, what is the differential diagnosis of the patient with hypercalcemia? Maybe on this side. Hyperparathyroidism, good. You know, I didn't use the audience response system, and I'm kind of regretting it now because the music was actually kind of nice. So on this side of the room, anybody give me a differential for hypercalcemia? You guys see this so often. Yeah, malignancy. Yeah, so those are the top two, right? Hypercalcemia and a malignancy. So let's just take a look at that. Yeah, so hyperparathyroidism, malignancy, thiazides, pretty common because they increase calcium resorption from the distal convoluted tubule, a lot of people on thiazides. Then some of these things get kind of rare. Yeah, renal failure, renal transplant. We don't get much milk alkali syndrome anymore because you can go buy your Zantac over the counter, right? So it's really the top two, hyperparathyroidism and malignancy. And so, here's my makeshift audience response, right? Poor man's. So what fraction of hypercalcemia is explained by primary hyperparathyroidism? Hands up for 10%. Hands up for 25% of all hypercalcemia explained by hyperparathyroidism. 50%. More takers. Now, how about 75%? No, so 50 maybe. How about 90%? Okay, so 50 bimodal distribution. See, look at that. Audience response right here. So 50% and 90%. All right, well, let's talk about this. So here's your patient, and then here's his subsequent workup. So the diagnosis is hyperparathyroidism in this case, and sometimes you can get these other things. I always like to get a 25-hydroxyvitamin D level. I mean, even in sunny Southern California, 1/3 of patients are vitamin D deficient. Too many computer games. You know, and so I think it's much easier to establish the biochemical diagnosis when the patient is vitamin D replete. If the patient is extremely vitamin D deficient and the calcium's kind of borderline and the PTH is up, you're wondering if they just have secondary hyperparathyroidism because of the vitamin D deficiency. 24-hour uric calcium, I don't always get it. I get it in cases when people are sort of as a borderline diagnosis or if there's a clear family history of hypercalcemia and I'm worried about FHH or familial hypocalciuric hypercalcemia. All right, PTH, RP, I rarely get. PTH-related peptide, those I would only get as after I've excluded primary hyperparathyroidism and I'm looking for somebody with cancer mediated by PTH-related peptide. I don't usually get that. It's kind of an expensive test. Okay, and after that, this is sort of the standardized workup that you're accustomed to. Remember, so I'm going to go some review, and then I'm going to talk about what's new. This is the review portion. Now, sestamibi scan and ultrasound are the workhorse tests for primary hyperparathyroidism. I want to advise you that the sensitivity of these tests varies from 50 to 95% based on your institution and who's doing the scan. All right, so not all of these scans are the same. You have to do a fair number of these to actually get good at them. There is a quality improvement process involved in this, okay? Most patients, 90% of patients with primary hyperparathyroidism have single adenoma. Those are the patients that are relatively easy to cure. And then there are 10% with multiple glands that are abnormal. Those are the more challenging cases, and we're going to focus a little bit on that. Okay, complicated chart. You don't even need to know too much about this, other than I'm going to pose the question, how would you ever figure out what percentage of people with hypercalcemia actually have hyperparathyroidism as the cause? You would have to know everybody's calcium level in Clark County, for example, and then you'd have to know everybody's PTH level, and you'd never be able to find that out. But one person knows what your calcium is, and that person is Kaiser. So in Kaiser, we were able to query everybody's calcium level, and then query everybody's PTH level, and then we found that of patients with chronic hypercalcemia, some 7,000, and it's a 3.5 million subscribers. That's like the state of Ohio, okay? So that's like an island within Southern California, Kaiser. So 7,000 people have classic primary hyperparathyroidism with hypercalcemia and a PTH that's above the upper limit of normal. Another group of people had hypercalcemia and a PTH that was in the normal range. What is the diagnosis there? It's primary hyperparathyroidism, right? So if you took calcium and dripped it into my system until my serum calcium was 10.6, my PTH would be 7. It would suppress. That's normal negative feedback. So if you have somebody who's hypercalcemic, if their calcium is 11.5 and their PTH is 42, they have inadequate negative feedback. That patient has a parathyroid tumor, okay? So don't let the normal ranges deceive you. The normal range is only normal in the appropriate context. With me? So that patients can have inappropriately normal or inappropriately non-suppressed PTH if they are hypercalcemic. That diagnosis gets missed all the time. And then there are a small number of people who might have cancer, who might be on a thiazide, and that's a small number of people. So when we looked at all of the hypercalcemia within Kaiser, this is what we found, that about 90% of people with hypercalcemia have either the classical or the non-classical form of primary hyperparathyroidism. And then there are some people with possible primary hyperparathyroidism because they had multiple high calcium levels and they didn't have a cancer and they weren't on the thiazide, but their PTH was never checked. And then there are a small number of people, less than 10%, who have malignancy as a cause. So if you have a patient that has a high calcium level on 2 occasions, there's a 90% chance that patient has primary hyperparathyroidism, and that is the most important thing I have to say to you about this disease, and this is new. This is our data, and it's new. All right. A little bit about epidemiology. This is also new. Within Kaiser, we were able to look at primary hyperparathyroidism as a function of age, race, sex, because we had so many people, and we discovered that the incidence and prevalence is a function of all of those things. It's 3 times more common in women. It's a disease of postmenopausal women. It's a disease of African American women. Whoever knew that? Because before this paper that we published, just a year ago now, primary hyperparathyroidism had never been studied in somebody who wasn't white. Okay? It's amazing, right? 2015. So there is significance. All you need to remember about this, women 3 times more common than men, women over 50. And those are the women you worry about, right? Why do we do parathyroid surgery at all? Why do we even do it? It's to prevent osteoporosis in postmenopausal women. That's all we're trying to do. Hopefully they don't. So you got to look for it in that group, and there is a significant racial variation. Most people don't know that. Okay, what about the prevalence? Look at the prevalence in women. In the past 15 years, it has tripled. So that now 1 in 400 women, adult women in the United States, will be affected with primary hyperparathyroidism this year, and 1 in 1,200 men. And why does the prevalence keep going up? Because we keep checking everybody's calcium, and not too many people get surgery, right? So we keep diagnosing it more and more and more and more, and only a small fraction of people get surgery, so then they never exit the disease pool. There's high entry in the disease pool and low exit. So I'm going to ask, how often should surgery be performed in primary hyperparathyroidism, and how often is surgery actually performed? So by show of hands, how many people send about 10% of their patients with primary hyperparathyroidism for surgery? How many? About half send them for surgery. How many? More than half send them for surgery. All right, so this is so a lot of hands, more than half of your patients are being sent for surgery. So I'll give you the numbers. About half of patients meet established criteria for surgery, which is the international consensus on primary hyperparathyroidism. Most people with this disease are asymptomatic, and they get sent for surgery if they have osteoporosis, the calcium's super high, like greater than 11.5, whether or not they have hypercalciuria is also important, things like that. So half of patients meet established criteria for surgery, and about half of those actually have surgery. So we'll go half and half again. Got it? And our data from Kaiser showed that a lot of people are running around having kidney stones, but somehow did not get sent to surgery. Kidney stones, a clear indication for surgery. So question is why? Elderly patients, unlikely to have surgery, even if they don't have significant comorbidities. A little funny, because this is a disease of the elderly. More than half of patients with this disease are over 60. And so I think that this disease is undertreated, and I hope to convince you of that with this next slide. It's complicated, a lot of numbers, but this is the only pre-publication data I will show you. I intend to submit tomorrow. So this looks at fractures. All right, everybody knows about bone density in hyperparathyroidism, but we don't really care about bone density, do we? We care about fractures. Bone density is just a surrogate indicator of fracture risk. But fractures are so rare that we really don't know a whole lot about how commonly people fracture in this disease and whether or not surgery is better or medicine is better. So I would just want to call your attention to two numbers. Women with hip fractures who have parathyroid surgery, their risk-hazard ratio of having a hip fracture within 5 years is 0.3. In other words, there is a 70% reduction in the hip fracture rate in this population within Kaiser. Now, the nice thing about Kaiser is employer-based insurance, right? People can only change insurance when they change jobs. So they stay within Kaiser. And we know that they didn't leave Kaiser and then have a fracture elsewhere. If they had a fracture within Kaiser, we caught it. So 70% reduction in hip fracture risk after parathyroid surgery. But then you might say to me, well, compared to observation, but what about medical management? What about bisphosphonates? Look at the fracture risk associated with bisphosphonates. It's greater than 1. We found that bisphosphonates were actually harmful. I'm not sure why that is. The bisphosphonate companies are not going to be happy when they see this, the drug companies. But I'm just telling you the data we found within Kaiser. Okay, so if you want to prevent hip fractures in postmenopausal women, send them for surgery. You'll save them from that. All right. My patient has an elevated calcium but a normal PTH. We talked about that. It's non-classic primary hyperparathyroidism. I've shown you that this group with atypical biochemical features makes up half of the disease burden. If somehow we miss these folks, we are missing out on half the opportunities to prevent fractures. My patient has an elevated PTH but a normal calcium. Is this primary hyperparathyroidism? What do you think on that side? Probably secondary. And you're going to check the vitamin D. Are you going to check the creatinine? Sometimes a little bit of vitamin D deficiency and a little bit of chronic kidney disease shoot your PTH up to 256, right? So we really have to assiduously rule out secondary hyperparathyroidism. Now here's the number one question. I think my patient has primary hyperparathyroidism, but the scan is negative. What should I do? Who's been in that situation before? Lots of people, okay? Who would still send that patient to surgery? Who would say, maybe not a great idea to have surgery? Not sure. I would like to convince you that the scan, what shows up on the scan is irrelevant. It's only relevant to the surgical strategy, which is not your job, that's my job, to get that problem out. So in terms of making the diagnosis, it's a clinical diagnosis. You establish a biochemical diagnosis and your patient's got osteoporosis, surgery. That's all you need to know. The strategy should be up to the surgeon. That's why you're paying the surgeon. But this happens, okay? And I'm going to bring you to what's new. What's new is dynamic parathyroid CT, also known as 4D CT, high sensitivity, 97% sensitive for localization of abnormal parathyroid glands. So if you look, this scan tells a really interesting story. This patient has had a missed parathyroidectomy, right, a failed initial operation, and it was so aggressive, look, they took out the thyroid on the right. You see that? Well, the thyroid's here, but the parathyroid is here. It wasn't even on the right. It was stuck between the esophagus and the spine. See that? Here's a parathyroid that I missed. I missed this one. It is in the carotid sheath below the clavicular head. They are in funny places sometimes. Okay, I missed that one. I went back out and I got that one because of this parathyroid CT. Where is this one? It's in the carotid sheath up near the carotid bifurcation, right? See the thyroid way down here. So if you did an operation down here near the thyroid, you wouldn't even be close to that. You would have missed it all. There would be no chance to succeed in that operation. Where's this one? Substernal, right? And this is the most irritating one of them all. Where is this one? It's sitting on the aorta. So what you see here is the left subclavian artery and the left common carotid, and this thing is like sitting on the crotch between, I mean, what the heck is it doing there? It's got no business being there. But this is why, like of all the operations I do, parathyroid is the most humbling because the variation is probably the most variable part of the human body, right? Normal parathyroids are these tiny little stupid things that are like 4 millimeters across, and you're supposed to find them, and they can wander around and end up in people's chests and things like that. So it's taken me thousands of operations to get good at this. It has the longest learning curve of any operation I perform. So parathyroid CT is different from a regular CT. I want to just counsel you that if you send your patient for a regular CT, two things will happen for parathyroid. It will be negative, and then when you try to get a really dedicated parathyroid CT on that patient, then the insurance company will deny it because they'll say that you already had it, because they don't understand the difference. So it's a different positioning. You got to get the shoulders out of the way. You got to get any like fillings out of the way, all these things that can interfere. The amount and timing of the contrast bolus, timing of image acquisition, and the radiation dose. We use the minimum radiation dose. Interpretation by a single experienced radiologist. Actually, he was recently married, but you know what I mean. So this one guy, Dr. Sepidari, and we've gone through this iterative quality improvement process. So we scanned 100 people in a year, and then every time I would operate, and then we would meet and say what was good about the scan, what was bad about the scan. We did that for a year, and after a whole year, he went back. If we have time, he went back and reread the first 6 months of studies because he knew that we had collectively gotten better. And there was a patient that had T-scores of -4 who'd flown down twice to see us from Seattle who had a failed prior parathyroid operation. And she flew down, got the CT, it was read as negative. I said, I'm sorry, ma'am, I really hope that this new technology would help you. It's negative. She flew back to Seattle. And then a year later, when Dr. Sepidari reread the first 6 months of scans, he said, Michael, I think I've got something on there because I'm better now at reading them than I was when we started. And I want you to take a look at the scan on that lady from Seattle. And we saw something. I said, yes, that's it. Called her in from Seattle, operated, and cured her. So I'm just trying to impress upon you that there is a learning curve for all of these things. And we weren't ready to really make this scan prime time until like 1 to 2 years after we started. And now we're in year 3. We were year 4 now. We are rolling. We are getting hundreds of these scans every year, mostly on patients who have had failed prior parathyroid surgery. We see a lot. I dedicate 1 day every week to patients with failed neck surgery that I have to reoperate on. But this quality improvement process is very important. When to get it. History of prior failed parathyroid surgery, history of any prior neck surgery. If the patient has thyroid nodules and also all sorts of graves or something, may as well get yourself the best test. Or maybe the soft indication is if other imaging tests have been negative. Sometimes the patient just wants to have some security. Sometimes you might want to have a little extra security. Sometimes it might make the surgeon feel a little bit more comfortable to operate. We operate on plenty of patients every day with negative scans. It's no problem. You just have to have experience, and you'll cure those cases. But just remember that 4D CT is highly sensitive, and do not let negative imaging dissuade you from sending your patient to surgery. If your patient has a calcium 12 and kidney stones and the imaging is negative, they still need an operation. They're sick. They have a tumor somewhere. The surgeon's job is to find it. Let them figure that out. Okay, I don't have a whole lot of time. I'll skip that. and go quickly to adrenals, and I'll show you a scan of a lady who had an incidental, she just had pelvic pain, and she had an incidental discovery of this mass right here in the right adrenal gland, and it's a good size. It's about a 3.5, 4 centimeter mass. So she comes in to see you because she had this scan in the ER. So what are the important points on H&P in the last 6 minutes? What are the relevant points for history and physical in a lady who with an incidentally discovered 4 centimeter right adrenal mass? What's the blood pressure? Good. Looking for hypertension. Looking at the potassium, looking for hyperaldosteronism. Excellent. Signs and symptoms of Cushings. Very good. All right, so I really like this. You guys are thinking about hyperfunction, hypersecretion, and that's the key. You really want to look at these things, right? Is the patient hypertensive? Does the patient have a known malignancy? Right? 50-year-old ex-smoker, lung cancer, adrenal mass is a metastasis. So the top 3 in the differential for somebody with a known invasive cancer is metastasis, metastasis, metastasis. The cancer loves to go to the adrenal glands. It's got this rich blood supply, it's a rich soil, and then tends to go there. Pheochromocytoma symptoms, headache, flushing, palpitations, hyperaldosteronism, usually not a whole lot of symptoms, but this is the patient who's on 4 and 5 antihypertensive drugs, and you just can't seem to get them better. If the potassium gets really low in these patients, they can have muscle cramping, particularly at night or after they've exercised. Cushing's, weight gain, striae. The best history and physical test for Cushing's is, ma'am, do you bruise easily? Now, a lot of women will answer yes to that question. Then the follow-up question is, show me a bruise. Show me one of your bruises. And if she rolls up her sleeves and she's got bruises on her ankles and legs, that's Cushing's. If she shows you a bruise on her trunk, what is the diagnosis? Bruise here, bruise here, bruise here. Domestic violence. So I'm serious. You guys are gonna face this, right? Extremity bruising in Cushing's. Everybody with Cushing's has a bunch of bruises on their arms and legs. All right. So we see a lot of adrenal incidentalomas because we get a lot of scans. And depending on the patient's age, it can be up to 6% of people who get abdominal CT scans are found to have an adrenal incidentaloma. Now, once again, avoid overtreatment is my best advice to you. So here you had a surgeon come here today to tell you to avoid surgery, right? For both thyroids and adrenals. So most common, for hypersecretion, we're looking for surgery is reserved for people with hypersecretion or too big for comfort. All right, so let's go through just this quick pie chart. So what are most adrenal incidentalomas? Most of them are non-functioning adenomas that do not require surgery. Again, most incidental findings don't require care. It's hard to improve patients' health if the patient's fine to begin with. You do see some pheochromocytomas, some cortisol-producing adenomas, some aldosteronomas, and rarely carcinoma, devastating, 400 new cases per year in the United States. Rare to see. So the biochemical workup, you're mainly going to look for these 3 things, pheo, hyperaldosteronism, and Cushing's. That's what you're going to collect for each one. 24-hour urine collection for catecholamines, serum aldosterone and plasma renin activity, and there are any number of ways that you can look for Cushing's. I usually like to see a plasma ACTH and a 24-hour urine-free cortisol. I like the 24-hour urine tests. They're inconvenient for the patient, but they're very reliable, and they're quite specific. Just a quick graph, a quick table on how to interpret catecholamine results. Now, a lot of people have headache, flushing, and or palpitations, and have hypertension, and have minor elevation in the 24-hour urine catecholamines. But the best advice I have for you, if it's not double in the urine, if it's not double the upper limit of normal, do not get excited about pheochromocytoma. Virtually every pheochromocytoma I have seen, we have one once every 3 weeks in our practice, double. Something in the urine test is double the upper limit of normal. That's the main message of this slide. All right. Size. I'm going to go quickly here. I'm so sorry. I'm running a little low on time. I apologize. But in terms of size, If it's greater than 5 centimeters, the likelihood of malignancy starts to take off non-linearly, all right? So 5 centimeters or greater, that patient needs surgery. 3 centimeters or less, the likelihood of cancer is very low. That patient can avoid surgery and undergo surveillance every 6 months with another CT scan. Then we have this intermediate area, 3 to 5 centimeters, and in that patient, you're going to assess their comorbidities and make a risk-benefit type of decision. That makes sense? So the intermediate category, you really want to assess the patient's level of surgical risk and whether or not they can tolerate that procedure. Laparoscopic adrenalectomy, almost all these tumors can be removed using a minimally invasive technique. This is the lateral transabdominal technique, 4 ports. We operate for about an hour and a half, 23-hour stay, and at the end, all the patient has to show for it is a couple little Band-Aids. This is what's new, retroperitoneoscopic adrenalectomy. So we used to do it like this with the patient lying on their side with 4 little Band-Aids there. Now we position like this, a vaguely pornographic slide, I apologize, and then we do it from the back. And here's what it looks like. So the patient's head is over here, the feet are down here, we find the spine, we find the paraspinous muscle, we go sneak underneath the 12th rib, make a small incision there, and 2 little stab incisions on the side. And this is what it looks like when it's healed. A little line there and 2 little dots there and there. So what's really new is we did this for about a year, and then we said, well, could we do it with even less? Could we do it with a single 1-inch incision in the back, like that? And this is 3 weeks now we've been doing this, okay? Now, you make this little incision, and then you insert this device, which looks and feels a lot like a jellyfish. And it allows you to convert a single orifice and insert 3 instruments into it, because the gelatinous material creates an airtight seal around these things. And this is what it looks like when we're doing the operation. So you see we've got 3 instruments going through that one jellyfish thing, right? And then this is what it looks like. Then you can break up the tumor a little bit and then bring it out, and then sloop, comes out like that with a little port, all right? And then, so that's what it looks like when we close, and that's what it looks like afterward. And I'll tell you, nobody ever looks at their back in the mirror. So I don't know what my back looks like. So the patients feel like they've barely had anything at all. You know, they don't realize the scar is even there. So we're the first in this country to do a single incision retroperitoneoscopic adrenalectomy. I'm hoping that this will that we can popularize the technique and make this a standard of care for these tumors. Now, I'm a little over time, but just to summarize, adrenal incidentalomas are very common. Evaluate for endocrine hyperfunction and assess the size. Almost all tumors can be removed endoscopically, and now you know about the very latest. You know about single incision retroperitoneoscopic adrenalectomy. That's the way I would want to have my operation done, because let's face it, it's pretty cool, right? So thank you so much for your attention. I'd be happy to take your questions.
Questions for Dr. Ye? Raise your hands and we'll get you the microphone.
Hi. Okay, got it.
This will be 40 years since I started an endocrine fellowship at USC in thyroid, and with all respect to all the advances in all the genomics and all that, we've been pretty accurate over the years which ones to operate and which not. But there's one that's all bets are off, and that's the Hürthle cell adenomas. How do you handle those?
Hürthle cell adenoma is challenging in terms of diagnosis, and I agree that remains the Achilles heel. So a Hürthle cell adenoma often can't be diagnosed as benign or malignant until you've done the diagnostic hemothyroidectomy. So I agree with you. That's still a frontier for us.
Dr. Ye, what do you recommend in terms of following thyroid nodules that are FNA benign?
FNA benign, if you can palpate it, then I would just do a physical exam in 6 months. If it's a sonographically detectable one, ultrasound in 6 months to a year. And then if it's stable, then you just graduate them. Just like your other things, you graduate people to every 2 years, and eventually you might stop. Yeah, good question.
Solitary thyroid nodule,
Yes.
That you've documented on ultrasound. Why not scan? And if the scan shows it to be hot, do you still need to do the FNA?
Right. Question is, why not do a scan? Well, it turns out that of all thyroid nodules, such a small number are hot, a tiny number. So you'll end up getting so many negative scans. Does that make sense at all? Like the prevalence of hyperfunctioning nodules is like 1 or 2%. So it's cheaper to just get the TSH. And if the TSH is suppressed, then do the scan, and you'll save money and trouble that way. And maybe I'll take one last question.
When would you use suppressive therapy on a thyroid nodule?
Great question. So when would you use suppressive therapy on a thyroid nodule? The answer is we do not, because there's a lot of high-quality data to show that it does not, putting people on high doses of thyroid hormone does not suppress the growth. There's level A evidence to support that. Thanks, everyone, for your attention.